The following podcast is part of a certified educational activity titled Striking Back at ALL, Achieving Lasting Benefits with Bispecific Antibodies and MRD-Guided Strategies Across Disease Settings. Access the entire activity and complete the post-test at peerview.com/XKA860. Downloadable slides and practice aids are also available.
Hi, this is Dr. Nicholas Short from MD Anderson Cancer Center in Houston, Texas. Welcome to this microlearning activity, Striking Back at ALL, Achieving Lasting Benefits with Bispecific Antibodies and MRD-Guided Strategies Across Disease Settings. The goals of this program will be to increase your understanding of the prognostic and clinical relevance of MRD assessment in ALL, augment your knowledge of evidence supporting bispecific antibody platforms in different ALL treatment settings, sharpen your skills for developing personalized treatment plans that leverage MRD assessment and antibody-based treatment in newly diagnosed and relapsed refractory ALL, and to enhance your ability to address practical considerations when using bispecific antibody platforms in ALL, including dosing and safety management. We'll achieve these goals through a series of concise educational modules that will explore topics such as the role of MRD assessment in ALL treatment, the further integration of bispecific antibody platforms into disease management, and the practical dosing and safety aspects of using off-the-shelf immunotherapy in the clinic. This microlearning activity offers you the opportunity to learn based on your own preferences and interests. Let's hear more about this unique format before we begin.
Find out how much you know about optimal management of ALL through a simple 3-step process in this self-assessment activity comprising 6 question modules. First, answer the baseline question to evaluate your knowledge and skills. Next, review the supporting evidence shared by Dr. Short. Finally, answer the question again to demonstrate what you've learned. Each correct answer automatically counts toward post-test completion, which means that getting your CME credit is fast and easy.
You've just answered a question about the role of bispecific antibodies in ALL. Let's review the ALL treatment landscape and the role of modern therapeutics in Philadelphia chromosome negative and Philadelphia chromosome positive disease. So here's a timeline of the recent innovations in the treatment of B-cell ALL. We have a number of drugs that have been approved in the last few years, starting first with blinatumomab that was approved for relapsed refractory B-cell ALL, and then inotuzumab, also approved for relapsed refractory B-cell ALL, and then 2 CD19-directed CAR T-cell products also approved in the relapsed refractory setting. Now, blinatumomab has also been approved for patients with MRD-positive disease, but outside of this MRD indication, there's no approval for any of these other novel immunotherapeutics in the frontline setting. But as we're going to discuss, there's been a number of new regimens that have been developed and are being studied in clinical trials, and some very exciting data that is leading to some of these agents being used in standard practice in the frontline setting, even outside of their current labels. So along with these new therapies, we have seen improvements in outcomes of patients with B-cell ALL. So here you can see on the left side, data suggesting that we made significant improvements when we first started using intensive chemotherapy for most of our younger patients. For example, we moved to hyper-CVAD based regimens. That's something that I use at my institution. And then with the introduction of, for example, CD20 targeted therapy such as rituximab, there was yet another improvement. And then in the more recent era, in the last 10 plus years, that we've been using, had access to inotuzumab and blinatumomab, we now see even further improvements in outcomes to where now for most patients, younger patients with Philadelphia chromosome negative B-cell ALL, we can often achieve long-term survival rates over 60%. However, there's still a lot of work to be done. Unfortunately, many of our patients still relapse despite these therapies. And actually, there's data to suggest that historically many patients with ALL didn't even receive any of these, any effective therapies. This was particularly the case for older patients, where it was often considered relatively futile to treat these patients because there were not effective therapies for them. However, as we'll discuss in these modules, there are now some new innovative approaches using low-dose chemotherapy along with these novel immune therapies, particularly for older patients, where we're now seeing encouraging outcomes. So here's an algorithm from the NCCN guidelines, just showing some of the drugs that are available first for patients who are relapsed refractory B-cell ALL. And just as we showed in a couple slides ago, you can see those drugs that we talked about, blinatumomab, inotuzumab, and those CD19 CAR T-cell therapies. This is just to highlight that really in the relapsed refractory setting, we rely primarily on these immunotherapeutic strategies rather than chemotherapy, because these have been shown to be more effective than standard chemotherapy. Now, even if we look at the algorithms in the frontline setting, you can see that some of these agents are now being used in the frontline setting, particularly blinatumomab. So if we look, for example, at this algorithm from the NCCN, you can see that those patients who with Philadelphia chromosome negative B-cell ALL who achieve a remission, then we assess them for MRD. In the setting of MRD positive disease, blinatumomab is clearly indicated, as we'll discuss later. For those patients with MRD positive disease, we usually recommend for those patients to then undergo allogeneic transplant, although not always. For patients who are MRD negative, typically those patients have continued to just receive standard chemotherapy, but actually you can see now that in the NCCN guidelines, blinatumomab is also recommended for MRD negative patients, and that's based on some recent randomized data that we'll discuss. So one of the preferred regimens from the NCCN is actually the ECOG 1910 regimen. This is a pediatric-inspired chemotherapy regimen that integrates blinatumomab into consolidation. And that's because there is a randomized study showing that this regimen was better than the ECOG chemotherapy regimen without blinatumomab. So there are compelling data as far as an overall survival benefit for the use of blinatumomab as consolidation, regardless of MRD status. And that's why this is one of the preferred regimens in the NCCN guidelines. If we look at patients who are older and may not be suitable candidates for these types of intensive regimens, NCCN guidelines also support the use of various blinatumomab or inotuzumab-based combination regimens, such as a mini hyper-CVAD with inotuzumab and blinatumomab, among other regimens. So MRD assessment is a critical part of both selecting treatment and determining the success of a given treatment option. Let's learn more about MRD in adult ALL. So first, I think it's important to realize that there's a number of different groups and physicians and other providers that are involved with the management of all of our patients with ALL. Here you can see a number of different ways that all of these different parties interact when we're treating a patient. And here I just want to highlight the important role of the pathologist, which is someone who, of course, will help us to decide on the diagnosis and the response to treatment. And in the context of what we're going to be discussing now, are really integral in helping us to assess for measurable residual disease, or MRD, which has a lot of important prognostic and therapeutic implications for our patients with ALL. So first, what is MRD? MRD used to be called minimal residual disease. Now we call it measurable residual disease because it's really, it refers to disease that's detectable beyond what we can detect with morphological evaluation. So patients who have under the microscope, when we look at their bone marrow, they're in remission, but we have more sensitive tests now that can detect low levels of residual disease in these patients. Now, we use the term measurable residual disease because it really depends on what assay we used, whether we're able to measure the disease or not. So, for example, we have flow cytometry, which is typically sensitive only to about 10 to the minus fourth. Now we have next generation sequencing-based MRD assessments that are sensitive to 10 to the minus sixth. So you can imagine situations where patients may have MRD detectable by this more sensitive next generation sequencing assay, but not by the flow assay. Also, it's important to notice that these assessments of MRD are dynamic. So you can have patients who are MRD positive early on in their treatment course who can then achieve MRD negativity later. And unfortunately, we don't know. There are some patients who are MRD negative who will still relapse. That's the second curve that you can see here. Our goal for all patients, though, is the third curve, which is to render them MRD negative with the most sensitive assays that we have and ultimately cure the patient. Now, as I mentioned, there's a number of different assays that can be used for MRD assessment. These range from flow cytometry at 10 to the minus fourth, PCR assays, and in the US, we're typically doing PCR for BCR-ABL for patients with Philadelphia chromosome positive ALL. And the most sensitive assay that we have clinically available are these next generation sequencing assays for MRD. And these look for clonal rearrangements of either the immunoglobulin heavy chain or the T cell receptor. And again, these are sensitive down to 10 to the minus sixth. So they can detect very low levels of residual disease. The recommendation in NCCN and also in general, what we recommend for any MRD assay in both ALL and in other types of leukemias is to try to get the MRD from the first pull of the bone marrow aspirate, because that's where you're going to have the most accurate assessment and the least risk of hemodilution. So we already talked about some of these different assays and to some extent their sensitivity. They have different advantages and disadvantages. So thinking about some of the advantages for flow cytometry, for example, this is relatively fast, relatively inexpensive, and it can detect some phenotypic shifts that might be clinically relevant. We won't talk much about PCR for these immunoglobulin or T cell receptor rearrangements because even though those are well standardized outside of the US and some European countries, we don't really have access to these at most centers in the US. Now, we do use the PCR for BCR-ABL very commonly, and this is a very simple assay that can be used with the standard PCR that we use, for example, for patients with CML. Now, the next generation sequencing MRD assay, the biggest advantage of this is that it is very sensitive down to 10 to the minus 6, and it can allow for the tracking of very small subclones. Now, there are some potential disadvantages of these different MRD assays. Flow can be challenging sometimes. It can be altered by the types of therapies that patients receive, particularly if they received CD19 or CD22 targeted therapies. And there is a lot of variability between labs because it does take the interpretation of the pathologist, which can vary from person to person. As far as PCR for as a method of MRD in B-cell ALL, the main limitation to this, or the main disadvantage, is that it only applies really to those patients who have Philadelphia chromosome positive ALL. So it's unfortunately not a usable assay for the vast majority of patients that have Philadelphia chromosome negative disease. Now, the next generation sequencing assay is actually well standardized, and there aren't too many disadvantages now, aside from it requires a lot of complex bioinformatics if you actually want to use it outside of the standard commercial assays. But fortunately, we do have commercial assays that can do this and that are well standardized. However, it can be more expensive than the other MRD methods that I talked about, specifically flow or PCR. So when should we measure MRD in patients undergoing ALL therapy? Well, per the NCCN, we should, at the very minimum, assess MRD after induction and after consolidation. But I think in general, in many of our practices, we often want to measure MRD after every cycle of therapy until a patient achieves MRD negativity, because we know that the earlier patients achieve MRD negativity, the better the outcomes, and the later that MRD negativity is achieved, those patients will typically have worse outcomes. So serial MRD assessment is very important. And even after patients achieve MRD negativity, it's important to continue to assess for MRD, because if you ever see patients convert from MRD negativity to MRD positive states, those patients have a high likelihood of relapsing in a relatively short period, and they should be intervened upon with whatever therapy is appropriate for that patient, either blinatumomab, transplant, etc. And so just going back to specifically the NCCN algorithm, you can see that the NCCN recommends at least after at your first response assessment to look for MRD. For patients with residual MRD, blinatumomab is indicated. Although, as we'll talk about later, even for MRD negative patients, blinatumomab is often used now. So let's look at how current evidence supports treatment decisions in patients who present with residual disease after frontline intensive chemotherapy. So here's a case of Robert, a 55-year-old man who has Philadelphia chromosome negative B-cell ALL. He receives hyper-CVAD and gets 4 cycles of treatment, so 2 cycles of hyper-CVAD, 2 cycles of methotrexate and cytarabine, and undergoes MRD assessment using this next generation sequencing MRD assay that shows 2,000 residual sequences per million, which equates to an MRD level of 0.2%. The question is, what are the treatment options for Robert? Should we continue with hyper-CVAD, or should we switch to another treatment? And what are the guideline recommendations for a situation such as this? So again, going to the NCCN guidelines, as we recently discussed, you can see here that for patients who achieve remission but still have residual disease, the recommendation from the NCCN is to give blinatumomab for eradication of MRD. It is often recommended that these patients are then consolidated with an allogeneic transplant, although, as we'll discuss, the data supporting this are not entirely clear, and often it's an individualized decision. So what are the data actually supporting the use of blinatumomab in this particular setting? Well, this comes from the BLAST study, which is a study of 116 patients with B-cell ALL who achieved remission, but had MRD at a level of 0.1% or higher after at least 3 cycles of intensive chemotherapy. Blinatumomab was given at 15 micrograms per meter squared per day for 4 weeks, and then followed by a 2-week treatment-free interval, and was given for up to 4 cycles. And the primary endpoint of the study was looking at complete MRD response after just 1 cycle of blinatumomab. And 78% of patients achieved this MRD negative remission after just 1 cycle of blinatumomab. So we see very rapid MRD clearance with blinatumomab and at very high rates of MRD clearance. So here are the data from the BLAST study. So actually looking at overall survival, you can see a very clear improvement in the long-term outcomes for those patients who received blinatumomab and achieved an MRD negative remission, which fortunately, as I mentioned, is the vast majority of patients who receive blinatumomab in this setting, because we do see very high rates of response to blinatumomab when we're using it to treat MRD positive B-cell ALL. And so this is a final analysis from the BLAST study that really confirms the same findings, I think, with longer term follow-up. And I think what's interesting from this is you can see among those patients who received blinatumomab, achieved a MRD negative remission, we actually start to see a tail of the curve. It's around 50%, 40 to 50% long-term survival, suggesting that we can cure a number of these patients with blinatumomab is treated for MRD positive disease, which if we don't target that MRD, the outcomes really are historically were very poor, where most patients who have persistent MRD after initial chemotherapy will eventually relapse and unfortunately die from leukemia. We've certainly improved outcomes when we give blinatumomab to these patients. So looking at the data in a bit more granularity, this is what happened to these patients and treated with blinatumomab and who achieved MRD negative remission, and importantly, what is the benefit of transplant in this setting? So I think it's important to note. So here you can see that among patients who were transplanted, more of them at last follow-up were alive without relapse. More of them, however, died without relapse, and fewer of them overall relapsed. So how do we put all this together? So I think the bottom line is that consolidating a patient with allogeneic transplant after they achieve MRD negative remission with blinatumomab certainly reduces their risk of relapse, but it's counterbalanced by this risk, unfortunately, of transplant-related mortality. In the end, a many analyses have suggested very similar survival between those patients who undergo consolidative transplant versus those who are either monitored or just continue with either maintenance blinatumomab or some other maintenance therapy. So it really is an individualized decision what we should do for these patients after they convert to MRD negativity. In my own practice, I'm often using their genomic characteristics, and those patients who have otherwise high-risk disease might be good candidates for transplant. Those patients who don't have high-risk genomic features, sometimes we can monitor them, and many of those patients can still be cured with blinatumomab for MRD eradication. So what are the options when faced with a patient with B-cell ALL who is MRD negative after initial treatment? So let's explore options in this consolidation setting. So here's a hypothetical case. So Robert is a 55-year-old man with Philadelphia chromosome negative B-cell ALL. He's treated with 4 cycles of hyper-CVAD, and then has MRD assessed by flow cytometry that is MRD negative with a sensitivity of 0.01%. So the questions are, what are the therapeutic options for Robert? Do we continue with hyper-CVAD, or do we move to some other therapy? And are there any data to suggest one approach might be better than the other? So this brings us to a very important study that was recently reported, which is the ECOG 1910 study, which addressed a very important question. So it randomized patients who achieve initial MRD negative remission with this pediatric-inspired ECOG 1910 chemotherapy regimen. So patients are MRD negative at a sensitivity of 0.01%, and they were randomized to receive what we would consider standard therapy, to continue with that same chemotherapy regimen, or to receive a consolidation that consists of chemotherapy with blinatumomab. So these patients receive at least 4 cycles of blinatumomab in consolidation if they're randomized to the blinatumomab consolidation arm. And so here you can see the top level data, which I think are very impressive. You can see a very clear, significant improvement in overall survival for those patients who are randomized to the blinatumomab arm. It's, again, emphasizing these are patients who are MRD negative. Like, of course, we already know that blinatumomab is indicated for patients who receive initial chemotherapy and then are MRD positive. Here, it answered the important question, what if they're MRD negative? And you can actually see a long-term survival over 80% for those patients who had an MRD negative remission with initial chemotherapy and then received blinatumomab as part of their consolidation. And unfortunately, the outcomes are significantly worse for those patients who received standard chemotherapy consolidation without blinatumomab. And so this is really a practice-changing study. Although there's not currently an FDA indication label use of blinatumomab for these MRD negative patients, this is now integrated into guidelines where blinatumomab is certainly an option and really recommended for patients who achieve MRD negative remission with standard induction therapy. So this study actually initially had an arm that was looking at among MRD positive patients, randomizing them to blinatumomab or not. Now, after we had the data from the BLAST study, which is a single arm study showing the benefit of blinatumomab for MRD positive disease, those arms were closed. But there are some initial data that at least support the BLAST study to show that there is a survival benefit for patients who are MRD positive who receive blinatumomab. This isn't that surprising based on those data, but it's nice to see randomized data supporting the use of blinatumomab in the MRD positive setting. Now, going back to the MRD negative cohort, there were some interesting data that were presented to suggest that those really the patients who benefit most from receiving blinatumomab are those patients who are able to receive 4 cycles, the full 4 cycles of blinatumomab. We don't really know why this is. Certainly, there are reasons that patients might not have received 4 cycles that might be related to why they might have worse survival. So, for example, if they had toxicity, et cetera. But I think the most important thing is, so first of all, you can see that among those patients who received 4 cycles of blinatumomab, the outcomes are excellent with long-term survival over 90%. But it shows that our goal should be that to not only give blinatumomab as consolidation, but if we can, to give all 4 cycles of blinatumomab to our patients as consolidation. Now, I showed you data from the randomized study that showed a survival benefit, but blinatumomab consolidation has also been looked at in some other studies. Here's data from a regimen of hyper-CVAD with blinatumomab. You can see how if you giving hyper-CVAD to patients, how you could integrate blinatumomab into the regimen. In this particular regimen, the chemotherapy from hyper-CVAD is actually truncated from 8 cycles to 4 cycles. So patients receive 4 cycles of hyper-CVAD, followed by 4 cycles of blinatumomab consolidation. And then the maintenance phase is your standard POMP maintenance, but alternating three months of POMP, 1 cycle of blinatumomab, and actually an overall shortened maintenance phase where POMP is usually about 3 years in maintenance. Now it's only 1.5 years with this chemo plus blinatumomab maintenance. So these are data from a single arm study, but they are largely replicate the encouraging data from the E1910 study. You can see here that the 3-year overall survival for patients who received the hyper-CVAD blinatumomab regimen was 81%, which is very similar to what's seen in the E1910 data. So I think this is largely confirmatory along with those randomized data that I just showed you. So you've just seen a question about newer combination platforms that feature antibody components. Let's see what the evidence has to say about these strategies. So there are a number of ongoing clinical trials and some that have been published showing the potential benefit of adding these novel immunotherapies such as inotuzumab and or blinatumomab into the frontline setting. So here we'll talk largely about using these drugs for patients, older patients, so often patients who are 60 years of age or older, who are not good candidates for intensive chemotherapy, such as full intensity hyper-CVAD, or wouldn't have been good candidates, for example, for the ECOG 1910 chemotherapy plus blinatumomab study. So here are some studies looking at the combination of chemotherapy with blinatumomab. There was a study that was published from the SWOG group looking at blinatumomab and POMP, and it achieved actually remission in 2/3 of patients who are older, and these are quite older patients with a median survival of 75 years, very high rates of MRD negativity. Overall survival still only around, here was a 3-year survival of 37%, likely reflect because of this very older population. Now, there's even more encouraging data, I would argue, from the German group. They did a study called GMAL-BOLD. They compared their standard GMAL regimen of chemotherapy with a chemotherapy plus blinatumomab. In the chemotherapy plus blinatumomab arm, they treated 50 patients with a median age of 66 years. The overall response rate was 85%, again, with the vast majority of patients achieving MRD negativity. And here, the 3-year survival was actually 67%, so better than we saw, for example, in the POMP and Blina study. And actually, this group then did an analysis comparing the data from this to the historical data from the GMAL regimen in the same age group, and found that the blinatumomab plus chemotherapy was associated with significantly lower rates of relapse and improved survival. So although it's a comparative study, it's not a randomized study, it does suggest the benefit of blinatumomab even in these older patients, just like blinatumomab has been shown to benefit younger patients who are getting intensive chemotherapy. There's a number of studies that have looked at low-dose chemotherapy with inotuzumab as well. So we'll talk about a couple of these studies. So there was the EWAL-INO study. This is a study looking at inotuzumab and low-dose chemotherapy in older patients with CD22 positive B-cell ALL. The median age was 68 years. The overall response rate was 90%. We still see very high rates of MRD negativity with these INO-based combinations, just like we see with blinatumomab. And the 2-year survival rate was 54%. There was recently published the Initial 1 study. This is a study looking at inotuzumab induction followed by age-adjusted chemotherapy. In this study, they treated 43 patients with this regimen. The median age was 64 years. All of the patients responded, so 100% response rate, and 71% of whom achieved MRD negativity. And here the 3-year survival rate was 73%, and you can see the survival curves there. So shows that these INO-based induction regimens in combination with chemotherapy are very effective, just as those combinations, as I just showed you, with low-dose chemotherapy and blinatumomab. Now, the question is, what if we include both of these drugs? So essentially, we know that these are very effective agents, blinatumomab and inotuzumab, in the relapsed refractory setting. Can we bring them into the frontline setting, particularly for these older patients, which will allow us to reduce the chemotherapy for these patients or potentially even eliminate it entirely so that we can improve their outcomes without introducing treatment-related morbidity and mortality that can come with chemotherapy? So at MD Anderson, we've done a study of mini hyper-CVD, so low-dose chemotherapy, initially with adding inotuzumab, and then later on, we then also added blinatumomab to this regimen. We've treated 80 patients overall with this regimen, median age of 68 years. All but one patient, or 99% of patients, responded. 94% of patients achieved MRD negativity by flow cytometry, and the 5-year survival rate is 46%. There's recent data from the Alliance study that's very interesting because it's a chemotherapy-free regimen of inotuzumab and blinatumomab in these older patients with a median age of 71 years. Despite the fact that there's no chemotherapy in this regimen, 96% of patients responded. And we await longer-term follow-up data, but the initial survival is encouraging with a 1-year overall survival of 84%. So moving on now to talk about Philadelphia chromosome positive ALL, which we haven't talked about much now. Here's an area where we can use blinatumomab in combination with a BCR-ABL tyrosine kinase inhibitor in a chemotherapy-free regimen for these patients and achieve very good outcomes, which is notable because historically Philadelphia chromosome positive ALL was one of the most aggressive and lethal forms of leukemia, and now it's actually one of the most treatable and in many cases curable forms of leukemia, even without any chemotherapy. So this was shown first by the Italian group in the DiAlba study. This is a combination of dasatinib and blinatumomab. This study was conducted using first 3 months of dasatinib and steroids. And then after that 3 months, patients received up to 5 cycles of blinatumomab. The study was open to adult patients with newly diagnosed Philadelphia chromosome positive ALL of any age with no upper age limit. And they treated 63 patients. The primary endpoint was the molecular response rate after 2 cycles of blinatumomab. So overall, very high rates of response. So the CR rate was 98%. And important, very high rates of molecular response. And after a median follow-up of 18 months in the initial publication, the overall survival was 95% and the disease-free survival was 88%. And they've recently published longer-term follow-up data of this, showing that about 4 years long-term survival rates of around 80% with this chemotherapy-free regimen. It is notable that there are some patients that may not respond as well, or at least may not have as good of durable remissions with this regimen. This is particularly those patients who have what we call the Ikaros plus or IKZF1 genotype. These are patients with IKZF1 deletions with either a CDKN2A or B or a PAX5 deletion. These patients do have worse outcomes with these regimens, but that's also been shown with other regimens, including intensive chemotherapy in pH-positive ALL. So this is still an area of unmet need for patients with pH-positive ALL. At MD Anderson, we've done a study of ponatinib and blinatumomab. So ponatinib is, I would argue, a more potent BCR-ABL tyrosine kinase inhibitor than dasatinib, and it's also active against T315I mutations, which are a dominant mechanism of relapse in patients who are treated with a first or second generation TKI. In this study, we start at 30 milligrams of ponatinib and then decrease to 15 milligrams once patients achieve a deep MRD remission. We also start the blinatumomab in the very beginning. So we give 5 cycles total of blinatumomab in combination with ponatinib, and then patients receive at least 5 years of ponatinib maintenance thereafter. The survival outcomes have been very encouraging with a median follow-up of 16 months. You can see a 2-year overall survival rate of 88%. And very importantly, we've only transplanted 2 patients to date. And so this is very notable because this is now converted. We believe that now Philadelphia chromosome positive ALL, again used to be one of the most fatal forms of leukemia that existed, is now one not only treatable and with chemotherapy-free regimens, but also one now where we may not need to transplant all of these patients. So let's explore some of the practical dosing and safety management strategies associated with agents such as blinatumomab and inotuzumab. So I think we can talk here a little bit about how blinatumomab is dosed. So it's important to note that blinatumomab dosing is different for patients who are over 45 kilograms versus under. This mostly applies to if you're using it in a pediatric patient, but sometimes there can be patients where the dosing will be relevant and you need to do weight-based dosing for those patients who are under 45 kilograms. In induction, we typically start at 9 micrograms per day for the first week, and then escalate to 28 micrograms per day. And blinatumomab is given as a continuous infusion, 4 weeks on, 2 weeks off. Dexamethasone premedication is very important to prevent the risk of cytokine release syndrome and may also play a role in reducing the risk of neurotoxicity. And those are the two most important toxicities that we do see in patients with blinatumomab. Here is just some of the adverse events that we're seeing in the TOWER study. This is the study looking at blinatumomab versus intensive chemotherapy in the relapsed refractory setting. Of course, these are relapsed refractory patients, so we see high rates of adverse events overall. I would just point out that there was a 5% rate of grade 3 or higher cytokine release syndrome, as well as a 9% rate of grade 3 or higher neurologic events. And these certainly may be these are certainly associated with blinatumomab, and these are toxicities that we should be aware of when we're treating our patients with blinatumomab. So when we're treating a patient with blinatumomab and they develop something like cytokine release syndrome, it's important to be aware of how to manage that toxicity. This slide shows management of grade 3 or higher, or specifically grade 3 cytokine release syndrome. What we do for most patients, again, talking about those patients who are 45 kilograms or more, we want to interrupt the treatment with blinatumomab, so stop the infusion. That's one of the most important things. Patients should be treated with dexamethasone. Typically, we give 8 milligrams every 8 hours for about 3 days, and then can taper it off. And then once the cytokine release syndrome is resolved, we usually want to reduce the dose of blinatumomab. So, for example, if a patient is on 28 micrograms per day, we reduce it to 9 micrograms per day, and then escalate again, sometimes increasing the steroid premedication. For patients who have lower grade cytokine release syndrome, we do something similar, but may not use as many days, for example, of the dexamethasone, and also may just resume the 28 microgram per day, for example, if a patient had very, very minimal cytokine release syndrome. I think one thing it's important to note, cytokine release syndrome essentially is a constellation of different symptoms, but often one of the hallmarks is fever. It's always important to do an infectious workup for these patients because there is a small percentage of these patients who will have a concomitant infection, and that can be very dangerous if it's missed. Okay, so moving on to the treatment of patients with inotuzumab ozogamicin. Patients with inotuzumab should be premedicated with a steroid, an antipyretic. Usually we're using Tylenol, and an antihistamine because there can be infusion reactions. Here on this table, you can see what the standard dosing for inotuzumab, the way it was approved in the randomized study that led to its approval. It's given in weekly dosing. So on day 1, patients receive 0.8 milligrams per meter squared. Then on day 1, they receive that. On day 8, they receive 0.5 milligrams per meter squared. And then on day 15, they receive 0.5 milligrams per meter squared. I would point out that in some of our contemporary clinical trials, we're often using lower doses of inotuzumab and sometimes fractionating the doses, which may decrease the risk of some complications. But it's important to be aware that these are the data, or these are the numbers and doses based on the FDA approval. So one of the most important complications with inotuzumab is the risk of sinusoidal obstruction syndrome or veno-occlusive disease, or VOD. So it's important to prevent this in patients receiving inotuzumab. So how do we do that? So proper selection of patients is key. So we want to avoid using inotuzumab in patients with underlying hepatic dysfunction, for example. Typically, if we're using the standard FDA-approved dosing of inotuzumab, we want to limit inotuzumab to 2 cycles when feasible, which ends up being a cumulative dose of inotuzumab of about 3.6 milligrams per meter squared. And although there's no good data to suggest this, I would say most experts would recommend to use ursodiol prophylaxis because that's been shown in the peritransplant setting to reduce the risk of VOD. So we often use that for patients receiving inotuzumab. Now, despite adequate preventive strategies, some patients still will develop VOD. This can occur in 10 to 15% of patients treated with standard doses of inotuzumab, and up to 25% of patients who undergo transplant. Early and rapid diagnosis of VOD is key to improve outcomes. The main thing to do in this setting is to discontinue inotuzumab and not rechallenge it, because that can precipitate a recurrent VOD. And then otherwise, management of VOD is the same as in the peritransplant setting. Diuretics, sometimes patients need hemodialysis, and defibrotide is the only approved agent in this setting. Other inotuzumab-related adverse events that we see can be cytopenias, hepatotoxicity. Of course, it's important to distinguish between your typical hepatotoxicity and VOD. And then infusion reactions are relatively rare, and they can be prevented with the pre-medications that I already mentioned. So understanding the toxicities of these drugs is extremely important, not only the prevention, but also management of toxicities that can come up with inotuzumab and blinatumomab. These agents are widely used in the relapsed refractory setting, and this is where they're FDA approved. But as we've seen in these modules, blinatumomab is being used, of course, for MRD positive B-cell ALL, but now there's data supporting blinatumomab in the MRD negative setting. Inotuzumab is being used in a number of treatment protocols, particularly for older patients in combinations with low-dose chemotherapy. And so these agents are really being used widely across the spectrum of the treatment course and trajectory for patients. And so it's very important to be aware of the toxicity managements of these agents.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/XKA860. This activity is supported by educational funding provided by Amgen.